think we'll have a very less crowd. I'm very thankful to AIOS and all my speakers, and we are the only one who are going to have a discussion, and I'm sorry I have to leave also because I have a flight. So I'll be discussing the challenges in diabetic vitrectomy. This is the first talk. How to control the bleeding. I don't have any financial disclosures. So diabetic vitrectomy is like a war. We have to control the bleeding and prevent the formation of retinal breaks. I always instruct that if there is a hemorrhage, it's better to stop, control the bleeding so that visibility is not a problem, and then proceed with the surgery. So with the advancing technologies, better viewing systems, I think the success rate has greatly improved, but still I think diabetic vitrectomy is still a major challenge, and we always, if I have a diabetic case, I am always prepared beforehand. So this is a simple diabetic TRD case in which you can just do most of the dissection now with the help of these 25 gauge cutters. Scissors is rarely needed. So most of the removal of these bridging tractions can be done with the help of a cutter. You can go very close to the retina, do most of your dissection, just trim them, and if there are any bleeders, you can just diathermize the use a cautery or even endo laser to stop the bleeding. And if there are no breaks created in such a case and the retina is flat or there is a mild traction, there is no need to put a tamponading agent also. So in this case, just after doing the vitrectomy, PRP was done. So however, as I said, if there is a mild bleeding, you can just cauterize it. A bimanual approach in diabetic vitrectomies is very helpful. You've got two hands, you can aspirate with one, you can do a diathermy with other, you can do even laser with the other, you can coagulate these blood vessels. I always recommend to do vitrectomy outside in rather than starting at the optic disc, because if there is a hemorrhage at the optic disc, a massive hemorrhage, then sometimes the surgery becomes very difficult to proceed. Still, if the bleeding is not controlled, you can either manually press the bleeder with the help of the cutter or a soft tip, or you can just now raise the IOP by just pressing a button with a foot switch. Now it has become very easy, but you have to be very careful that the optic disc is usually compromised in such patients, and you can hamper the bleeding. So the IOP should, you can hamper the perfusion of the optic disc. So it's very important to lower the IOP, recheck the bleeders, and monitor the time the IOP is raised. So this is another video just showing the outside in approach. So I always prefer to clear the vitreous from the periphery, and then once that is done, this is the central tractional band which is present at the optic disc, which is causing a localized TRD. So just, and then you can gently release these bleeders. So generally with this approach, you can avoid a massive bleeding, and the majority of the peripheral work has been done. So again, after just doing the cutting the vitrectomy, I am not using any scissors. Most of the dissection now I do with the help of a cutter only. And after releasing all these tractions, if you're lucky enough not to have created any break in a detached retina, then you can go ahead without any intraocular gas or silicone oil. I usually avoid in diabetic cases. So again, once all the dissection, this is released, you can coagulate these bleeders. Endo laser is also very good. Sometimes in diabetic cases, I prefer to do a foveal sparing ILM peeling also, as in this case, and followed by a panretinal photocoagulation. However, still if there is a persistent bleeder, it's always better to plug all the plots and better to use valve cannulas, wait for some time. In most of the cases, the hemorrhage will stop. However, still if there is a persistent bleeding, then I'm very fond of using these heavy liquids, PFCL. If there is no break in a tractional retina, you can use PFCL. But if there is a break in the tractional TRD, in the area of the TRD, the PFCL can go subretinal. So it's always better to use PFCL if there is no break. So PFCL, it pressure tamponades the bleeder, and then you can remove the membranes under PFCL. So this was a case in which there was a persistent bleeding which was coming from the optic disc, and after injecting PFCL, then I remove this membrane with the help of a forceps. You have to be very careful because it can lead to formation of breaks. So very gently and a tangential traction. So if a clot is formed at the disc and it's not very large, you should not try to remove it. It will lead to rebleeding, which can be much more worse. You can do endo laser under PFCL. It pressure tamponades the retina against the RP, and we get a good laser reaction, and then you can proceed with your case. So this is another video in which I just wanted to highlight that I've done everything. There is a hemorrhage which is present underneath the PFCL bubble. I will remove this clot, but at the end of the surgery, there was again the formation of the clot. So sometimes it's better that if you have a small clot which is formed at the optic disc and the retina is well attached, you should not try you should not try to be very heroic and remove all the clots, because the secondary bleed can be more problematic. So although I removed this bleed under PFCL, so in the end of the surgery, when I did an air fluid exchange, there was some amount of bleeding which again came, so it was not very fruitful. Rather, I could just have aspirated the active blood which was there and left the clot. So this is at the end of the surgery. So this is another video in which again I'm just highlighting the use of PFCL. There was a tabletop tractional detachment. The peripheral retina is attached. It's a very old RD. So under PFCL, I removed this membrane which was very tightly adherent to the retina. So you have to be again careful. There are very high chances of creating a break. Lucky for me and the patient in this case, I didn't have a break. So, and if you don't have a break, you can just leave the tractional detachment. I did a peripheral laser in the attached retina. So this membrane is being removed under PFCL, and I had left the TRD which will settle over a period of months, take months to settle. But if you're sure, then there is no need to put silicone oil if you have not created a break, if you're very sure. So this is the laser which is being done in the peripheral attached retina. You can see that there is a tractional detachment which is present in the center, but I've relieved all the traction, and I'll just leave air inside the eye. So this is another video in which I'm using PFCL as a tamponade by tilting the eye, a small bubble. I did the peripheral retectomy. There is this center fibrovascular frond which is very tightly adhered to the central macular area. So there is a continuous bleeding. I have inserted a PFCL bubble. I'm just tilting the eye and continuing with the dissection. This is a case in which I use the scissors because the plane between the retina and the fibrous vascular proliferation was very close. So I had to be very safe, and this was a one-eyed patient. So under PFCL, some of the dissection was done, tilting the eye and doing other dissection. So I didn't want to be very aggressive in this patient, removing all the bands, because this was a one-eyed patient. So just relieving the traction and the maximum which I could give this patient. So I just go to the. So as I said, so PFCL can be used as a very effective agent for tamponading bleeders if they are not controlled. So this is the fundus picture at 1 week, and then at 1 month I just left this frond because this was a one-eyed patient. The patient gained a vision of 6/12 after 1 month. So if the bleeder is not localized and there is a continuous bleeding, it's always better to stop the surgery. You can give an anti-VEGF, but you should not do a blind surgery and create a break. Probably operate after some time if really it is so bad. And there is another option which I've used in few cases. I left PFCL inside the eye, like in a GRT, in which I've done quite a few, and then you can re-operate after about 3 to 5 days, remove the PFCL, proceed with your surgery, and you can use a intraocular gas or oil as tamponade. So this is again a use of PFCL. If you have found a proper plane, you can use PFCL to do the dissection. You just inject PFCL in the plane between the retina and the fibrous tissue. This can be used in cases in which the vitreous is not very tightly adherent. You've got broad-based adhesions, but you've got focal adhesions. So just inject PFCL in between the plane. It not only prevents bleeding, it also creates a separation between the retina and the overlying vitreous fronds, and then you can gently proceed with your traction, and I think that will also protect the underneath retina. So gradually in both the videos, the dissection is being done from the center to the periphery. I normally said from the periphery to the center, but in this case, since most of the adherence was present at the region of the optic disc, so I had to proceed from center out. So this is another approach which you can use. You can inject PFCL if there are not broad-based adhesions. So I'll just go forward. So again, prevention is best. You should have a good control of the hypertension, anemia, diabetes. Antiplatelet use in these cases should be suspended, maybe not in all VRs. If the patient is on anticoagulants, it's always better to do a INR and prevent excessive bleeding. So although they do not affect the final outcome, but they prevent bleeding intraoperatively and postoperatively. So a good systemic control is very good to prevent complications. So anti-VEGF, I think they have really revolutionized the management. Given 3 to 5 days before, I prefer to give it 3 days. They greatly reduce the incidence of bleeding, and they have made the surgery quite easy. So putting it all together, I think everybody has their own techniques. The ones which I highlighted, that it's better to use valve cannulas. You can use a bimanual technique, which is really helpful since you've got both your hands free. You can aspirate with one and coagulate with the other. It's always better to cut the hyaloid from the outside in approach. And the use of use of anti-VEGF agents, I've already said, you give it 3 days before. It really helps in controlling the bleeding. You should not try to pull a fibrovascular proliferation at the disc. It can lead to a very severe bleeding, which is difficult to control. And the use of PFCL, I've already highlighted. It really pressure tamponades the blades, gives a clear media. You can do laser under PFCL, and in very, very extreme bad cases, you can even leave PFCL inside the eye. But very important not to create a break in the tractional area. So thank you all for listening. And I just request the next speaker, Dr. Lalit Verma, to please come and give his next talk. And please, I request my other speakers to please take over because I have to leave and I have a flight. So I request Dr. Ajay, Dr. Drais, and Dr. Vishal to please come on the dais and please take over. Thank you.
Which all the VR surgeons actually do it, but sometimes you can be caught in a situation where despite taking all the described measures, still you may land up in issues. So thank Bhuvan for conceptualizing the course, although at the fag end, but still I think its topics are pretty good. So my job is to tell that if the cannula is not in position, what to do. So in all the vitreous surgeries, we keep stressing that infusion cannula is first in and last out, because that has to be there. And before we put on the infusion, we always check and confirm. The tip should always be visible. You cannot turn on. And whenever a resident or sister is visiting, sister will ask, tip visible, tabhi infusion on karna, nahi to nahi karna. So this is the general principle in all MIVS, all vitrectomies. But there are situations which, you should be careful. One is if it's a bullous RD. Bullous RD, sometimes the tip of the cannula may not be seen. Or if the choroid is very thick, because all of us are doing MIVS 23 gauge, 25 gauge, we mostly make two plane incision like this. So situations like RD plus choroidal detachment, situation like inflammatory conditions like endophthalmitis, uveitis, or if there is a gross hypotony. So these situations where I have also been caught that infusion cannula placement becomes slightly tricky. So this is one situation. I have only 2 videos to show. This one situation, a chronic endophthalmitis, recurrent endophthalmitis. So we decided to go ahead with vitrectomy because multiple injections had already been done. So notice we have started infusion in this eye, but somehow depression can't see the tip. It is obscured. So we make this opening in the upper temporal part. Ideally, it should have been made in the upper nasal part first actually. But with the help of this cutter, without the infusion being on, you cut this tissue which is obscuring the view of the, and then depress again. Depress again, there may be some tissue which is on the tip. You have to incise that with the MVR blade or cut it if it is possible. And once it is done, then you go ahead and proceed with the vitrectomy. This is another patient of actually again endophthalmitis, where it was hypotony. So what I did here was a needle infusion first. You can have a syringe with the needle attached, thin bore needle, and infuse so as to firm up the globe. So once the globe is firm, then comes this big cannula, which is a 6mm cannula. And the advantage of 6mm cannula, by and large, because it's not usually found on the table nowadays because we don't use much, is that the propensity to go through the sclera, the thick choroid, and the vitreous is very high. And second point is, do not angle it, go straight directly inside, then you will be able to see. So in case you saw here, after the needle infusion, we took this 6mm cannula and go straight inside. Because in classic MIVS nowadays we make 2-step incision. So this is another patient who had chronic uveitis, which was complicated with detachment. So left eye was okay. In the right eye, it was a predominant nasal detachment. So how we did this patient was, pupil was reasonably big, and there was this signs of uveitis. You can see on this anterior side of the lens, a lot of synechiae, a lot of broken synechiae, pigment capsule. So once we started this vitrectomy, you can see the illumination is much less, as if it is coming through the retina. But remember, you don't have to do too many movements at that time. If you keep going in and out, you may create issues. So whatever vitrectomy, I thought I will, whatever is visible, I'll do. You can see these breaks, you can see this all pigmented vitreous here, signs of old uveitis, large multiple breaks here. So did continue for some time, and after that change this position. So now suddenly the illumination has brightened up, and then we do the further vitrectomy. After some membrane dissection, injected 1 cc of PFCl, further vitreous dissection. Remember, this was a re-surgery actually. So change the position of the light pipe. Now suddenly the illumination has become very nice, because I shifted from upper nasal towards 12 o'clock more, although maneuverability was an issue. You see multiple breaks in the upper part also. Tried to peel off whatever membranes I could. Now both the instruments are inside. So now once we thought that everything is good, so we started this air fluid exchange. So once we started air fluid exchange, you notice this detachment is becoming bullous here, and air comes into here. This is the air which is coming to subretinal space now. Air is coming to subretinal space. So again, you have to pause for some time, recheck. You see, sometimes what may happen is in the beginning it's okay, but once you start with exchange, retina becomes bullous. So cannula which was in the vitreous, because the retina becomes bullous, this becomes subretinal then. So at this time, again recheck, again made another opening here. This opening was straight compared to the previous opening which was angled. So this is actually big cannula. So now again illumination is very good. So first job was to remove this air through the retinotomy. It came out from here. So then did air fluid exchange properly with no subretinal component of air. And then retina got settled actually nicely. Put in silicone oil. This was because his third surgery, and lasered all the breaks. Lasered entire 360 degrees. So this is post-operative picture, retina nicely settled and doing well. So take home is that there are situations where cannula may be subretinal or in the initial part, or may become subretinal. The tip of the red flag signs are the tip of the port not visible, or illumination becomes less, or RD suddenly becomes balloonous, and air going subretinal. So I try to show all these 4 things here. And if subretinal, maintain your piece. Do not suddenly take out the instrument and put more instruments. Frequent exchange of instruments should be avoided. Otherwise, you may push the retina so much that there may be a break formation or in the periphery. And sudden movements can lead to actually a lot of complications. Can change the position of ports like I did in relation to the bullous RD, and port entry can be one step instead of angle steps. These are especially relevant in situations where choroid thickness is expected to be more than usual. So you have to be mentally prepared that in such situation maybe 6 mm cannula. So whenever I do endophthalmitis, I normally keep a 6 mm cannula with me, or remember to put it straight. And then I think you can work very effectively. Thank you very much. These are the couple of thoughts, processes I had.
Thank you, sir. That was a beautiful talk. Any questions from the audience? I want to ask you, sir, sometimes do you feel even now a need to put a 20 gauge sutured cannula, because very, very rarely we still do that, like a hybrid vitrectomy.
Yeah, correct. So therefore, if you are, pre-operatively, you have seen the patient nicely and remember that this is a patient who has hypotony or who has end-off. So I will definitely insist that on the table you should have a 6 mm cannula, even at the cost of suturing, because that will definitely save. 6 mm cannula, I have rarely seen it will go subretinally or suprachoroidal. It will definitely go inside. So you're right, Raj, that you should, OT should, nowadays in modern day OT setups, people do not have this.
Forget about it.
Yeah, forget about it.
And so if you have a lot of choroidal detachment and hypotony, how many days would you like to give steroids, atropine before you operate a detachment? Would you like to wait, or?
Previously we used to wait for, a week or 10 days. Now not, because I will give steroids for maybe 2-3 days and then go inside, because the more you wait for choroidal detachment, it lands up to PVR. So you can't keep waiting. So you just want to build up the pressure. If the pressure, suppose patient presenting pressure 2, if it has come to 6 or 8, I will,
I'll just mention here, since you mentioned that, in fact, there is a patient I'm operating tomorrow, day after, who came to us with massive choroidal detachment, 360 degrees, with a retinal detachment which was seen. So I gave a suprachoroidal steroid for this patient. Within 3 days, the choroidal detachment mostly had settled off. Put on because he was obese, he's hypertensive, he's diabetic, and these patients I cannot give.
How many days?
Sorry, sir?
The super flattened out.
Yeah, it's within 3 days. The inferior one was gone, the superior one little bit remaining.
That's a good,
And
I think,
it's,
suggestion. Very good
and
suggestion.
it's a very easy method of doing. So,
Very good suggestion.
so no IVTA, it's a because you can inject in a choroidal detachment. You don't need any special cannulas. I use my own cannula.
All the more easy, actually.
And it works very well.
Very good.
Then other thing was, which I just want to mention, is that when you are having a cannula, and I've had this experience twice, when I was injecting oil, my assistant pulled on the cannula a little bit accidentally, and the oil started, so the oil was already half full, and then the oil started going subretinally. So it's very important that you tape the cannula. So the cannula is there, and we tape it so that they cannot pull it off. So that is something I wanted to share.
And the other thing is something we use, it's a very, very old thing, but midricaine, Deca and adrenaline and atropine. So if we have a lot of choroidals, we just give that 1 or 2 days before pre-op, subconj in the OPD, and that also helps. So something very, very old.
I also do that sometimes.
So midricaine is something.
Why adrenaline?
It's the midricaine, what we used to give earlier.
Yeah, so
It basically settles the ciliary.
Cycloplegic is important.
Cycloplegic and the barrier, blood aqueous barrier, etc. Yeah, and we don't. I think sir is right. The message is nowadays we don't really need to wait.
Nowadays we don't wait. Previously, when we were in RPC, we used to wait.
Yeah.
And land up in PV.
Even in SN traditional teaching was wait, but nowadays I think
So
the
if
concept
you
is
do
changed.
not wait, do you drain it on the table before starting?
Yeah.
Yes.
Yes.
That's what I'm saying.
Yes.
But the message should go
The
in.
message will be that you take depending on the phakic status, pseudophakic, you can put a AC maintainer
And
and
drain.
drain the choroid from outside
Correct,
first.
correct.
Yeah.
And the placement is, as sir showed, is very critical, because where there is a massive choroidal, you can avoid. You can put a nasal cannula or avoid that area if you know where it is from before.
Yeah.
That's another thing.
No, sometimes people say when you can even directly put your cannula into the suprachoroidal space, start the AC maintainer, it will keep draining. Yeah, I'm asking. So I think Sangeet has shown in the suprachoroidal space, so it's been.
Thank you so much.
Good.
So I thank sir, and I invite Dr. Ajay Arora to talk about submacular hemorrhage.
Can we have this? So I'll be sharing some thoughts on submacular hemorrhage during vitrectomy, how to proceed. So why managing subretinal hemorrhage is important? So without proper treatment, the visual outcomes in subretinal hemorrhage are poor. Why? Because there is a physical separation of the neurosensory retina from the retinal pigment epithelium, which leads to photoreceptor loss. There is subretinal hemosiderin formation, which causes toxic products to the photoreceptors. The photoreceptors may undergo traction because of fibrin and clot retraction, and then they can be subretinal fibrosis. So you should make sure that a subretinal hemorrhage is removed. Now, why would a hemorrhage occur? It can occur because of an inadvertent retinal damage, then bleeding while peeling vascular membranes, drainage retinotomy while doing a relaxing retinotomy, or the subretinal bleed while draining SRF in a case of a scleral buckle, when you have to immediately convert to a vitrectomy. So once it happens, so how to avoid it? You should pay attention that if there is a clot formation, it will immediately lead to a membrane formation, which is sticky and difficult to remove. It will also compromise the view, and a blood can go subretinally. So you should make sure that the patient's BP and heart rate are monitored. What we have found is whenever the heart rate is above 90, then there is a greater chance of even a suprachoroidal bleed from occurring. We manage it with mechanical pressure over the bleeder, increase the infusion pressure, which can be done now in a automated by a press, via a single switch press on the machine, or you could even raise the bottle height. Then the mechanical pressure by the PFCL, and also the PFCL causes the blood to move to the periphery, as I'll show you in my subsequent videos. We could also switch to air, because that will give us some clarity of visualization. Sorry. So then you can add thrombin to the infusion, and you can also add, which we used to do earlier, adrenaline to the infusion. So these are the preventive measures which I've already enlisted, and I'll just show you some videos. This is basically, this patient was pre-treated, a diabetic with a very bad traction. So where we have given anti-VEGF, and you can also use the proportionate reflux below the membrane. You can see the proportionate reflux. I was using it here, created a space between the retina and the membrane so that the hemorrhage can be prevented. So this way the dissection can be completed easily, and one can dissect out very difficult membranes without creating a break. So it's been shown by a group that they did on 28 consecutive patients a double-blind study of using 100 units per ml of bovine thrombin, which was added to the infusion. The mean bleeding time without thrombin was 111 seconds, but it dropped down to 12.3 seconds in cases where they added the bovine thrombin. The incidence of inflammation was there in 20% of the eyes, but it could be controlled with topical steroids. So this is a patient who had subretinal bleed. A PFCL is being injected, and the bleed is pushed, as you can see here, to the periphery, where we create a small retinotomy. We have lasered that area before, and now the blood can be easily removed by soft tip with an active suction, and you can actually try to remove it at one go, or one could use end gripping forceps and remove the bleed from the subretinal area. This is another patient where the blood is present just above the disc. We put in PFCL, create a small retinotomy, and one could then go inside with a soft tip cannula off, and the clotted blood can be removed with the same soft tip cannula, or rarely if required you can use an end gripping forceps to pull it out. You can see the entire blood clot coming out. Try to have patience, be a little slow, because otherwise, as it happens here, we have to go back again, but it's okay. One can remove it and it comes. You should try to avoid leaving blood there. So if necessary, add more PFCL so that you can push the blood and take it out from the retinotomy that has been created. So this is a large, this was a video which which I got from Dr. Subhendu. PFCL was injected inside the vitreous cavity after vitrectomy had been done, so it gave us a little clarity of view. And where he will do a large relaxing retinotomy. I have not done such a large relaxing retinotomy to remove the blood, but yes, that is possible. You can go subretinally and try to remove the blood, as much blood as possible, with an end-gripping forceps or a soft tip cannula. I'll just take it, and then once you've done that, then you laser it, put in silicone oil, and it does well. So this is a fluid air exchange being done, followed by endo laser to all the large relaxing retinotomy that has been created. So we have handled a large number of cases of a massive suprachoroidal hemorrhage, which needs a proper methodology of treating them. It is, once you have a massive suprachoroidal hemorrhage, it is better not to drain it immediately, because most of the blood would have got clotted. It's very important that in case you get into a situation where a suprachoroidal hemorrhage is occurring, that you close the eye immediately, otherwise you will lose the contents of the eye. So first thing is close the eye. Then you should serially follow these patients on ultrasonography. You can actually see the liquefaction of the suprachoroidal bleed. Usually we go in between 7 to 14 days when we drain the heme. But in case where we had 3 cases where we had limited suprachoroidal hemorrhage, it happened during phacoemulsification. We left it like that. Even the phaco was left in between. There was a lot of upthrust. We diagnosed it later on. And on the 23rd day after everything had settled down, went in again, did the phacoemulsification, and did well. These are some of the cases where just the steps, surgical steps of suprachoroidal hemorrhage drainage are shown. You can put in an AC maintainer. And this was done at the time of 20 gauge vitrectomy. We evacuate the blood by creating a retinotomy. This is again another patient where we did it from the infratemporal quadrant, and you can see here that these eyes, when managed well, you can actually end up giving them a reasonably good vision. Like this patient got a vision of 6/18. So it's important to manage them well. One thing which I wanted to bring out is the use of fibrin glue. I have not used it myself, but Dr. Mudit from LV Prasad, they have recently presented, and I will show you his video which they presented it just a few months back. So fibrin glue assisted hemostasis for the persistent intraoperative optic nerve bleeding is very useful. I'll show you the video for that. So basically you do a vitrectomy, do a fluid air exchange, make sure that the bleeders have been localized. After you've done your thermocautery, if still the bleeders are not have not been, still bleeding is occurring, then you use the Baxter glue, which has got 2 components, a thrombin component and a fibrinogen component. The thrombin is a thicker component. The fibrinogen is a thinner component. You should first put in the heavier one, the thrombin, wait for a little while, and then put in the fibrinogen, and it will actually go and plug the point of bleeder, and then you can just leave the eye and even come out without doing a fluid air exchange, or you can put in gas as you like. So this is one example of a fibrin glue assisted hemostasis during proliferative diabetic vitreoretinopathy, and this is Mudit's video which I'll just share with you. So you can see here that so this is the standard vitrectomy which is being done, and once they have done the vitrectomy, there was a persistent bleed from the optic nerve head. So at this stage, they are done the fluid air exchange. Once the fluid air exchange has been done, they put in the, they tried to do hemostasis by all methodology, did not succeed. So now a microdose injector is being given. I'll show you the microdose injector. So in this, the thicker part is just put in the optic nerve head. Now the thinner part is put in, and make sure that this is restricted to the optic nerve head. And once this is done, this coagulum actually disappears within a few days. The bleeders have all stopped. They go ahead and do a fluid exchange. Just air is put in, no gas is also put in. And this is 1 week later. You can see the coagulum on the optic nerve head. They have checked the visual function, and this is much later on. This patient got a vision of 20/20. So that's a fantastic outcome, and I think this might actually work out as a very good method of achieving hemostasis intraoperatively. So this is a small device which I have made. Microdose injectors are pretty expensive. They are disposable. So I have made a device so you can actually see it being tested out. We have used it in a few cases. So I'll just show you how it works. It's a foot control device, and you will be able to see that so with my foot switch, when I'm pressing the foot switch, you can see the drops coming in. And this I have used for subretinal injection of TPA. So when you do a subretinal injection of TPA, so this is just we are testing that, I hope, I'm not sure if you saw the drops falling on the thing. So you can actually make sure that a single drop goes into the subretinal space, and then we go inside, we have injected it, it worked pretty well. So take-home point is good systemic control, pre-op anti-VEGF injections, address any bleeding points during vitrectomy immediately, do not allow the blood to clot for a longer time, liberal use of PFCL, the infusion pressure can be elevated so that the bleeding can be stopped, and the ports, it's better to use valve cannula so that you can come out and wait for a while for the bleeders to stop. Judicious use of thermocautery and simultaneous, so I always use a chandelier so I can aspirate with one hand and do the cautery with the other. Use of fibrin glue. Do not panic, because when it happens you might panic. So do not panic. You can always, close up your surgery and come back another day, but you should try to finish it off at that time. Thank you for your patient listening. Thank you.
GRT flaps, what to do next? Sir, I just have a question to you. This is about the submacular hemorrhage, but what is your criteria if the hemorrhage is outside the arcades? If it's a large clot, it's a small clot, do you go inside, be a little aggressive, do a retinotomy and drain it? So what is your criteria of leaving it alone vis-a-vis, draining
So
it?
if I have a submacular hemorrhage and it's pre-operative, so what I was discussing was intraoperative. If it is pre-operative, we usually give a intravitreal TPA and put in gas. We want to displace it away from the macula, and once it becomes extramacular, the vision is restored. If it is extramacular, I think one could, if it is a small hemorrhage, and what they say, if it is less than 100 micron thick.
No, I'm talking of during vitrectomy.
During vitrectomy. So during vitrectomy, I put in PFCL over the macular area, try to make sure that the hemorrhage is gone away from the center. And in these cases, if there is a larger amount of hemorrhage, I tend to drain them. But if it is very thin layer, I would just leave it like that. Yeah. What is your take on that?
Exactly, but sometimes, the area of even a small blade is very next to the break.
Yeah.
And that hampers the adequate laser at the posterior
Laser,
limb, and that can be
correct.
tricky, and that I would drain. Otherwise,
Right.
I would leave it alone.
Right. But if there is no break in that area,
Then
you
I will
would
leave it alone,
like
yes.
that. So if I find, Daresh,
I want to ask you, if you have a bleed when you're draining a buccal, what is your threshold for converting to a vitrectomy and draining it, or putting just a bubble of gas in?
so
What is the
when
threshold?
supposing I'm draining and I think that there's some bleed has occurred, I would immediately see and turn the eye so that I do not allow the hemorrhage to go to the macular area. In case the hemorrhage is on the nasal side and it is unlikely to, then I would
leave it.
put in a pressure from outside, wait for it to stop and put in gas. But if it is on from the temporal side going subretinally
under
and
macula.
gone into the submacular area and it's a temporal RD,
Yes.
then obviously I like to drain it.
You would convert to
I
vitrectomy.
would like to convert it with. So you would, it's a good idea that you could put in gas.
Yeah, because
put
I
in
have a beautiful video. I think Vishal also, you presented a beautiful, yes, where you remove the clot And I think even when Vishal presented and I presented before that, the question was, why did you not put a gas bubble and make the patient prone? So we were both asked this question. That's why I wanted your guidance.
So
about what
I
you
think if we have a small bleed, I have not done it, but theoretically you can, after the buckle, put in TP and put in gas and make the patient prone. The same principle should hold, which we do in a normal case where we put in TP
So
otherwise.
my argument is it's a superiotemporal RD and only that area is detached. So even if you put gas, I don't think it's going to come into the attached retina and migrate. So I think it's better to take it out because it will just remain confined there. So that was my argument why I didn't want to put gas. So because it was only a superiotemporal detachment.
Yeah, but if
Maybe
it is
it's
a
a total
temporal RD
detachment,
going up to the macular area,
yeah, and if it's involving 6 o'clock, then maybe just gas because then it will be pushed down in that detached area. If the rest is attached, then I'm not sure. So that's
customize.
So So I'll be speaking on GRT, and there's one case where I would like Sir and Dr. Vishal's opinion also during this. So I'll just start the video. So obviously, if you are going to do a air exchange and not do a PFCL oil, there's high chance of slippage. And if it does slip, then we go back to saline, re-inject PFCL and do a direct exchange. Now in the MIVS era, the exchange has become a little tricky because earlier when we were trained, we used to just I'd ask the sister to switch the infusion cannula, which was a sutured 6 mm cannula, to oil, and the sister would put in the oil and we'd do the exchange beautifully. Now with MIVS, it's a little tricky. So this is something our group has described, the bimanual chandelier technique. So I'll just show you the video instead of speaking about it.
Core vitrectomy is done.
There's a
PFCL is injected to unroll the flap of giant retinal tear up to the posterior edge of the tear. Chandelier is being inserted as a fourth port for direct PFCL silicone oil exchange. Silicone oil is injected from the left hand, which is the non-dominant hand, and PFCL is removed via the flute needle with the right hand.
So this is a very simple and elegant technique, and I think there's a small animation also. This was all published in IGO a few years ago by my colleague Dr. Stuti. So basically you put PFCL, you unroll the edge, you have a chandelier light injecting, then you put the oil. As the oil comes in, you have your flute needle inside the PFCL bubble, you go down to the disc, you dry it, and that's how it ends. Of course, it looks simpler than it is. So then when I was doing a literature search, when Bhuvan invited me for this course, I found this very interesting article from Spain, where they've described a novel technique to avoid intraop slippage, the bimanual double aspiration technique. So I just show you the video this is from the article. This is a work by the Spanish author, Dr. Placaris. So this is the GRT, you can see the flap moving and they're doing the vitrectomy. And PFCL is put to unroll it. Then they just do the fluid air exchange. And now this is the stage where it can slip. So you can see now there's some posterior fluid and slippage. So they have a brush and they inject more PFCL, I think, and then they kind of unroll this. So this is the first stage. So you can see this is a nice maneuver you can do. And if you have two instruments which can unroll, is always better. So they're flattening the slippage and is assisted with the PFCL fill. So they're injecting more PFCL, and with one hand they kind of, at the posterior edge of the break, they're just aspirating. Once they do this maneuver, the retina is absolutely flat, they do laser. And now this is the interesting part. This is the bimanual double aspiration technique. So now they have a chandelier in place, and both hands they've got this soft tip brush needle. And one of them is kept at the edge of the GRT, and one of them is kept at the disc. And slowly they're doing the exchange. So the PFCL is coming out and air is being injected. And this ensures that as soon as anything rolls, then the brush needle is ready to kind of aspirate it. So I thought it's interesting, and they put oil and they found it very successful in their cases. So this was just something I thought is interesting to see what other people are also doing. Now, this is my case where I would like the opinion of everyone. So, this is a boy who's had multiple surgeries, trauma case. So this was like a 360-degree GRT. We do the laser to the edge of the GRT. It is a bad case. Now we start the exchange. So again, there's a chandelier. Left hand, the oil is going in. PFCL is getting exchanged. And right hand is a flute. So now the oil is coming in and we're aspirating the PFCL out. So this is the PFCL oil exchange. We're very happy. Everything is going on very well. And now we are in the bubble. And now what is this? Just look. It's like a fog. And now we can't see anything. We're absolutely frightened. There's it's all like some coagulated milky white thing. It's not coming out. It's really like a fog. You see, you can't see any retina underneath. This mixture of PFCL and oil, air. So we thought we'd wait for some time, nothing happened. We thought we'd remove it with the cutter, but it's nothing. And finally we had to aspirate the whole thing out. So most of it came out anteriorly, and then for the last bubble we had to do it under visualization. I don't know what happened. So see the last few bubbles you can't take out the bubble. You can go down with the needle. Sticky oil, but it's that the PFCL has all got denatured. Anyway, then we did the whole stage again, and now you can see it's flattened and it's fine. So this is some food for thought about what happened, and we'll discuss this in the discussion. This is another case which was interesting. This was a doctor who had a temporal GRT, and so this is the temporal GRT. And the laser is done. Everything seems to be going fine. We put the chandelier, we do our normal technique. So now we're filling up PFCL. So always before the exchange, important to have to cover the edges with the PFCL, so you don't have any rolling of the edges. Now we're putting the oil. And this is important that you get a good fill of anterior oil. So we're filling up anteriorly and waiting for it to come out of the port. Now we start the exchange. So I think so this is fine. The last bubble is coming. We feel happy, but look now. Look at this posterior fluid. So now we are wondering what to do, because everything seemed to have gone off fine, but these are posterior fluid pockets. So we kind of depress the edges to check if there's any slippage and whether the laser is intact. Luckily, when we checked the edges, they were all intact and there was good laser. So although those looks very scary, this was the next day. It was all flat, everything was fine. And no SRF posterior flow, it was dry and the GRT edges were flat. So you don't have to always react you can be inactive, you don't have to always go in for resurgery. One tip is we kept him turned laterally, operated side down for half an hour post-op and then prone. So maybe that helped the fluid drain, mechanically. So to summarize, GRT cases are challenging. These are some tips and tricks for you to help you with these cases. The MIVS chandelier technique is useful, and not every complication needs active remedy. Thank you. I'd like to ask Dr. Ajay what do you think happens in a milky?
3 things. One is that whitish material.
Yes.
Was it related to the different oil being used that day?
So related to?
The oil which we normally use, use some other make, because
No.
I've had 1 or 2, it was not so much, but a whitish material which probably is related to those, the oil has some property when you're done your vitrectomy, you have this whitish. So what I do is I keep injecting oil from the other side and keep aspirating this whitish material. I've had
that flocculent white.
Flocculent
that
thing. So
white like a streak.
So I have tried that going inside with the cutter and cutting it, and
Okay.
my assistant will tell me, sir, you're spoiling the cutter. So then I go inside with the hard tip and remove it with an active suction. And
That
it-
I've seen, but that I just leave alone. I don't
Ah,
touch that,
so
that what
it-
you're talking
yeah.
about. But this was very bizarre, I don't know.
And the other thing which I normally do is that I get my PFCL up to the edge of the GRT,
Yeah.
and then I don't fill it up completely, and then I go into the air mode, so that with the air, whatever, so I have not labeled as, I have not published that, but go into the subretinal space and remove all the fluid, and then massage the edges,
Yeah,
not bimanually, but
Yeah, yeah.
unimanually with the bimanual technique with the chandelier light on, and then massage it back, and then convert from PFCL to silicone.
Okay.
So
Yeah, would
Yeah.
work well. Vishal, any thoughts on this?
See, I always have found I have very different views of this, but honestly, I have found the slippage problem a bit overrated since I have started doing surgeries. Even when I was a very junior consultant, my teacher always told me that don't go under oil, go under air, and don't do a oil PFCL exchange. Now that helps in two ways. First, it gives you a broader view during the air exchange. It's less messy.
Yes.
The second thing, it always has a ironing out effect, the air.
Air,
A
yes.
small amount of slippage, if there is, oil will not correct it during the exchange, but air will correct
Yes,
it.
yes.
You just take an extra 10 minutes during the drying of the interior and it works very well. Never had a slippage. Always have read it, seen the video, not
Yeah.
personally experienced it. So I think it is a bit overrated for me. So, and the second thing, you showed a video on a bimanual aspiration,
Yeah,
and that was under chandelier.
Yes.
But then the air will create a lot of reflexes under chandelier. It's very difficult to see that edge.
Yeah,
if you're
yeah,
going under air, you generally switch off the chandelier, right?
Yeah,
we are
that was a Spanish group which has shown it, but yeah.
Yeah,
I just
but
thought
their
it-
view
it-
was
it-
much
view is
better
very
than
good.
what
I don't
we
know.
view in
Whereas
our-
I will show you videos with bad GRTs, 360-degree GRTs, and they settle well with air.
Just with air. So you don't do that direct PFCL oil exchange at all.
So
That's-
one
that's-
question which I have is, you have done a vitrectomy, you put in a belt buckle, okay?
Yes.
And during the surgery, you realize that you have to do a large relaxing retinotomy. Now, what do you do with the belt buckle? What
it's
are
a
your
three-
indications? So, if you done a, say, I would say 90 degrees versus 180 degrees, or you do a retinotomy, do you keep the belt buckle?
If
or
it's 360, I remove it, or if it's almost 360, I remove it. But if it's smaller, I leave the belt buckle. If it's a smaller one, especially if it's a phakic patient, then I would like I feel happy with the belt buckle because I know that I've not cleared all that peripheral vitreous.
What about you, Michelle?
I remove it if it's the same. But if it's a
Same.
short area of RR, then it's always
Then
good
you
to have a
always
temporal.
keep the belt buckle.
Yes.
So next we have, thank you, Nilesh. Next we have Dr. Vishal talking to us on globe collapse during vitrectomy, causes, sequelae and management.
Thank you, sir, and thank you, Bhuvan, for his very successful course. He conducts this course in Retina also, and generally a packed house there. So I'll be speaking on intraoperative hypotony. Intraoperative complications are rare in the modern era of surgeries and viewing systems related to retina surgery, but they can have serious consequences. Fortunately, most are preventable if you have a strong vigil. Common complications include, as we have seen, bleeding, slippage, light toxicity, post-operative hypotony, iatrogenic tears, etc. Intraoperative hypotony is rare because of the advanced fluidics, modern VR tools, and the use of valved cannulas. But it can occur in case in the hands of even of the most experienced surgeons. So the bottom line is early recognition and management prevents potentially devastating complications. So let's come to the causes. So it's always the fluid dynamics. So there's a mismatch of infusion and aspiration, and that mismatch most likely is because of infusion. So there can be a blocked cannula, a leaking infusion cannula, or a kinked cannula. Then you can have a high section and a low bottle height, which can cause hypotony. You can under air, if you're doing active aspiration, that can lead to intraoperative hypotony. And unnoticed infusion disinsertion because of indentation, because of a speculum related problem, it can get unnoticed, and when you see the hypotony interrupt, then you are aware of that. And with the non-valved cannulas, of course, the logic is simple. While working under air or fluid during vitrectomy, the globe collapses while you exchange the instruments. What does it lead to? It can, of course, lead to bleeding. It can lead to iatrogenic tears. It can lead to a clear lens touch, corneal edema, hazy view if not noticed early. It can lead to, again, bleeding in the subretinal space and lead to a submacular hemorrhage. And of course, it can lead to choroidal detachment. And what is the management guideline? The first line of management is to identify it early. If you identify it early, the complications will be less. The last is, of course, to manage complications that have occurred, check the machine parameters, the most important thing, the external support to the infusion line. And if you're using a non-wall trocar system, then you use plug while exchanging the instruments. So coming to the videos. So this is a very common cause. This patient was having a post-traumatic endophthalmitis. We have injected a 6 mm cannula, and there was a repeated hypotony because it was disinserting. You see the patient, the eye is already very inflamed. He's squeezing it so much, and the cannula is touching the speculum. So you do, the first thing is the patient should be comfortable. So in this, we augmented our posterior subtenance block in addition to the periburbar block. Now you can see the speculums are wide open, the patient is not squeezing, and these are the prevention tips. So this case is unlikely to get an intraoperative hypotony because of the infusion issue. So here you can see this is a routine macular hole surgery. The posterior pole is stained with brilliant blue G, and we are carrying on the ILM peeling, and nothing is going wrong here. And this is a non-valve system. Now when you go under air, now I'm actively aspirating. This is an old video. Now I'm actively aspirating, and you can see under air. If you are under fluid, it will not cause hypotony. If you're under air and you actively aspirate, you can see the the papillary edema and the folds. So that can lead to bleeding, and that can lead to iatrogenic tears, and that can lead to a posterior capsular touch also if your cutter is quite interior. Of course, 6 mm cannulas are, have to be there if there is a lot of hypotony and you cannot see the shaft. As Dr. Lalit was mentioning in his first video, they generally go in the vitreous cavity, but in this case you can see there was a lot of tissue even in a 6 mm cannula tip. So you have to see the sheen of the metal very clearly before turning the infusion off. And in this case we were, dissecting that tissue with the cutter from the opposite side before switching on the infusion. So a very common cause, of intraoperative bleeding, you have lasered everything in diabetic vitrectomies, everything is stable, you have dithermized everything, and you think everything, there'll be no bleeders. Now once you go under air, especially in non-valve trocars, the bleeding again starts. And that is because there is some amount of hypotony, especially with the older systems, and especially with the non-valve trocars, there is some amount leakage, and that intraocular pressure is not maintained, and the bleeders which are not supposed to bleed are start oozing out under air. So you have to keep that in mind and aspirate them quickly. If you are late, then they'll form a clot, a membrane, and especially if it's on the macula, it can be a messy thing. So complications can occur in any stage of the in any case, whether it's simple or complicated. This was a straightforward macular hole case. And again, you can see the macula is stained with the BBG, and even before the peeling part, you can see the temporal choroid. And then we looked, and the cannula was kinked, and we could not recognize it in time. And we changed the position away from the specular hub, and now still there are some amount of choroids left, but you don't have to do active intervention in small choroids. It will create more damage than benefit. You keep on doing your surgery, nothing will happen with a small choroidal like this, and the patient did fine under gas, and there was no post-op choroidal detachment remnant after a couple of days. Again, this was a combined drop nucleus and a IOL drop, and the incision of the frag, the 20 gauge incision was near the ciliary body, and there was no bleeding till we were doing the frag. But when we went for the IOL removal, and there was some instrument exchange during that time, and that caused a hypotony, you can see a trickling bleed over the macula. Of course, we could manage that easily. Before that, the volumes increase. Coming to myopic arteries, this is a very important cause of intraoperative hypotony and a cause of submacular hemorrhage. So this is a high pathological myopia, and you can see during the start of the surgery, because of the hypotony, there is a streak of blood, almost crossing the arcade and to the foveal center. But as I said, if there is a small streak, and especially in these complicated cases with thin retinas and hemorrhage being at the macula, you don't have to do anything. You just aspirate the fluid, close all the brakes, and put it under gas or oil, and this bleed will resolve in a few days. As contrary to this case also is a pathological myopia, and you can see because of the intraoperative hypotony, which was not present pre-op, there's a whole sheet of blood subretinally. So there was no view actually. So this cannot be left alone. This will not settle unless you drain that subretinal hemorrhage. So we made a large temporal retinotomy, made a posterior retinotomy, and drained both the areas because it was loculated, and we drained as much as we could, and we made the macula free of the blood and ensured that all breaks are lasered, and the patient did fine in the follow-up period. And what is important is what I asked Dr. Ajay sir also, how much of bleed you tend to leave and what is the safe limit. So this was my fellow's case, and he had operated, and there was intraoperative hypotony, and he left that and he thought nothing will happen. And you see, if it's a lot of blood, it contracts, it creates clots, and if it's near your periphery and near your brakes, it will contract and cause a re-RD. So we had to go inside, and you can see all the disorganized blood and causing a sheet, creating a sheet and contracting and forming new breaks also and enlarging the pre-existing ones. So you have to dissect, and it's again a difficult situation, and it's all very stuck to the retina. This is a case of a 6-year-old boy with the optic disc pit, and just to demonstrate what intraoperative hypotony looks like, it's an interesting view. So there was a pit, and we induced the PVD, we stained the macula with BBG, we started peeling. Now at this point you see we are doing an active aspiration, and because of the hypotony, and this is a non-valve system, you can see the egress of the fluid through the pit, which we did not see when there was a normal tone in the eye. This again, my fellow is doing a case. This was a rebleed, and we were doing a vitreous lavage. As you can see, after inserting the vent, there is no fluid egress, and that was not realized because there was a kink at the cannula, and it was, she thought that the lavage has been done, and she again went to clear the posterior capsule and did a vitrectomy in the hypotenuse stage. So when I came, there was a choroidal detachment, and because she had inserted the cutter inside a choroidal detachment, she created an iatrogenic break, which you can see in the temporal area, and then we finally had to settle. So a simple, straightforward vitreous lavage in a diabetic vitrectomy can lead to such complications if you're not aware of the position of your cannula and the ensuing complications. So to conclude, infusion misdirection results in hypotony, which seems to be infrequent, but it remains a risk. And the awareness of the problem is very essential because it has the potential to touch the retina, choroid, and lens, and can be avoided by maintaining the correct position of the cannula. You can tape the cannula, check the parameters, and place an external anchorage. Walled cannulas are always preferred to non-walled in maintaining the IOP, and even if it occurs, early management of complication is the key to success, lest things go out of hand. Thank you so much.
Nice presentation, Vishal. Any questions, Dara? So anybody has any questions, any suggestions, questions? So either we have conveyed all the message rightly or it has not been understood. So Vishal, what I have noticed practically is when we are operating, I don't know if you found out that sometimes you will find on the table that you have that sense that something is wrong. There is a hypotony occurring and slight choroidal, and you notice that your assistant is pressing over the cannula. The infusion is not coming. So despite you have done everything, he's just put his hand there, he's trying to do this, small things. You should immediately stop if so, you know, you get a sense, it's like an AI in your brain working that something is wrong. So you
That
should
comes with
immediately
experience, yes. But what I'm trying to tell you is that these complications over the past years, these are all old videos. So if you're using machines which are, you know, of Indian make, or who do not have proper calibration systems and using non-Voltrocars, you can face these complications. Otherwise, now we are all using, you know, maybe Constellation, maybe EVA. We have a good IOP control system, so hardly any calculation. But even then, that kinking of the cannula can be there, and you have to tape that with the.
I think the taping is very important.
Very important,
right?
very
Yeah.
important.
Because when we were doing 20 gauge, it was always sutured, so there was no need to put any tape.
And
But
what-
now with MIBS, I think just taping it on the nose or nasal bridge or somewhere on the side, on the cheek of the patient, I think that's a very important tip.
So one more thing I would like to highlight is in the present day, what I'm using is the Constellation Vision system, and in the silicone oil removal cases, in every second case, when I put the infusion, put the second infusion, start SOR, it becomes hypotenuse. Then I increase the IOP, and then it becomes okay, and then I continue with the SOR. Now what I've realized is, when you're inserting the cannula and you're inserting the second cannula, some amount of oil inside the eye pushes into the infusion cannula, and that you know, that level, you know, hinders the infusion flow.
Infusion, yeah.
So I don't know whether you have.
No, I think we like earlier when you did 20 gauge, you always tell the OT technician bottle height badhao, you know, at the time of, and now there's no bottle height to increase. So you just have to keep that on, like you can start it on even 60.
Yeah, what
And that 60 should ensure that little bit of oil which has gone back in the cannula pushed in, and then you start it off. But yeah, that's a good point.
So what I do is, you know, is just sometimes for speeding up your thing, when you have an oil-filled eye, when you put in the infusion cannula, so I normally it's said that you put in the first cannula, put in the infusion cannula. In a silicone oil removal, I do always 3-port. I put in all 3 cannulas and do not connect my infusion port. So that way nothing leaks out because they are valved. And once my cannula is there, then I put in my infusion cannula and I go inside and remove it. So that way there is nothing happening and I save time.
okay.
Thank you.
So any questions or we call it a day? Sorry?
All points are clear.
Right, thank you, sir.
So no question or
Any-
anything residual for us.
Thank you, sir.
Thank you, sir.
Thank-
Newer machines are so good
Yes, sir.
that there is no hype.
Right.
Only thing that's kinking problem. If there is any silicone oil and is there keeping the infusion canal,
Yeah.
there is obstructing things. So always try to use the new safe.
Yes.
But we all are reusing actually, so it becomes a problem at some point or the other. Especially, you know, single users not working in institutes, they have to reuse these things.
Yes.
In pediatrics, something I think I learned when I was at LVP for a short time, they use, if they're reusing also, they first put a needle and then they put the cannula, because if it's blunt, it has to use a fresh needle to kind of make a track and then put the trocar system, just a small tip.
So for that case, I would suggest to use my ANT system. My ANT system, which I have done, which all of you are aware of. Every time you will use a new trocar, because trocar is a hypodermic needle. So it will reduce your cost. You will never have problems. But since this ANT system is not supported by a multinational, so it's fine. Thank you very much.
Thank you so much.
Oh yeah.